Okay, so I think we can slowly start. Dear all, welcome again. My name is Mariangela Pellegrini. I'm the educational manager for the ERN-EuroBloodNet, European Reference Network on Rare Hematological Diseases. And I'm here with my colleague Daria, that we are both happy to welcome you on this sixth session of a comprehensive program. Named Topic on Focus from Willebrand Disease for Patients, Organization and Healthcare Professional. This program has been coordinated by the ERN and the Umbrella Patients Organization European Haemophilia Consortium, represented by the patient representative Baba Zimiele, that is also HIPAG, and in the steering committee of the EHC. And indeed, this educational program has steering committee I'm very proud of, because we can also count on the partnership with EURORDIS-Rare Diseases Europe, and it has been supported by members of the ERN-EuroBloodNet scientific committee, like Professor Sophie Susen from the CHU de Lille in France, Professor Jeroen Eikenboom from Leiden University in Netherlands, and Professor Flora Peyvandi from Ospedale Maggiore Policlinico in Milan, Italy. And so I'm proud to pass the floor to Daria, who will explain the background, organization, and logics of this session. Thank you, Daria.
Thank you so much, Mariangela. I'm Daria Camilli, Education and Communication Manager at the European Haemophilia Consortium, or EHC. It is an international non-profit organization representing 48 national patients' organizations for people with rare bleeding disorders from 27 member states of the European Union and most members of the Council of Europe. The EHC represents approximately 90,000 people diagnosed with rare bleeding conditions such as hemophilia, von Willebrand disease, and other rare bleeding disorders across Europe. Among all those bleeding disorders, von Willebrand disease is the most common bleeding disorder, affecting up to 1% of the general population. However, it is often neglected and still overshadowed by hemophilia. This program aims to distinguish von Willebrand from hemophilia and focuses on the particularities of this bleeding disorder. Within the framework of this program, we discuss very topical areas related to von Willebrand among patients and healthcare professionals as well, and we give visibility to the challenges of those living with this rare disease, including but not limited to quality of life, access to treatment and care, medical services available in Europe, diagnosis, treatment options, and the overall patient journey through life. And today, as Mariangela already mentioned, we have our webinar, the title of which, in my opinion, speaks for itself. We are going to discuss treatment options for patients with von Willebrand disease. And this is the topic of today. And I give the floor back to Mariangela to explain the home rules and introduce our speaker from the clinician side.
Thank you, Daria. So I will start explaining that this program is accredited by the European Board of Accreditation in Hematology. So each session means that you could receive one continuing medical education point. For receiving them, you just need to participate to the webinar and answer to the survey you are going to receive at the end of the webinar by email. It will take just 1 minute for answer. It's a very quick one. And then we will contact you and we will provide you the information about how many points you are eligible of. So do not worry, we will take care of informing you. And then I also would like to share other additional home rules, like you will see your microphone is muted and will be muted along all the speeches we are going to hear. But at the end of the lecture, we have a question and answering session where you will have the possibility or to unmute yourself and take the floor or write the question in the chat. So we will then take them and we will have a debate together. So as said, and as usually, we invite to every lecture an expert, healthcare professional, physician, and a patient representative. So today with us, I have the pleasure to introduce Professor Sophie Susen. who is Professor of Medicine and Department of Hematology of Lille University Hospital in France, and Head of the Department of Hemostasis and Transfusion. And Daria, do you want to introduce the rest of the speakers?
Absolutely. So we have a speaker from the EHC side. It's Cathy Verbraeken from the EHC von Willebrand Committee, and she's also the Dutch Haemophilia Society von Willebrand Disease Working Group chairperson. Unfortunately, due to personal reasons, she was not able to join us today, but I have a message from her, which I'm going to read to you, with her personal story and personal story of living with von Willebrand disease. And I also have Baiba Ziemele and Laura Quintas here from von Willebrand Disease Committee, who will also support the speech of Cathy with their own perspective from their countries. Baiba is from Latvia and Laura is from Spain. So a message from Cathy. My name is Cathy, I'm 38 years old and I come from the Netherlands. I'm the mother of 2 daughters and von Willebrand plays a major role within my family. I would like to share 2 experiences with you regarding the treatment options in von Willebrand. I think it is important to mention that we have a good healthcare system in the Netherlands and that we have good access to medical care. Unfortunately, this is not the case for everyone in Europe and beyond. Even in 2024, there are many countries, and even around the Netherlands, where there are little or no good care and treatment options for patients with von Willebrand disease. It is not entirely unimportant that in the Netherlands, as in many other countries, we are still facing with the diagnosis delay for the von Willebrand, and that despite good access to medical care, we, like many others, do not always receive the best care. For example, in the Netherlands, it depends on the treatment center, which treatment you will get because of the contracts the treatment centers have with pharmacies. In Rotterdam, for example, you would get Haemate, and in Utrecht, Willeid as a von Willebrand patient. As for the family story, our youngest daughter had surgery on her tonsils when she was 2 years old, and she had subsequent bleeding, which resulted in 5 operations. After many examinations, it turned out that she had an abnormality in her blood clotting, and we were referred to a treatment center. After a long time, she was diagnosed with von Willebrand disease type 2N. After this diagnosis, we as family were all tested, and it turned out that we were all affected by von Willebrand disease. Even though I was diagnosed with von Willebrand, my uterus was removed when I was 30. I had my periods 3 out of 4 weeks a month and could not function normally. I was homebound and could not properly care for my daughters. Every month, I received an iron infusion in the hospital to keep my iron levels up. The gynecologist, internist, and hematologist never discussed treating these heavy menstruations because of my von Willebrand diagnosis. At the time, I didn't know what the treatment options were and what, as a woman with von Willebrand, could I have used to perhaps preserve my uterus. Even to this day, many uteruses are removed from women diagnosed with von Willebrand when these heavy periods could also be treated. My youngest daughter has been menstruating since she was 9 years old, and she had her period from 12 to 14 days a month. Her treatment option was quite simple, the contraceptive pill. We didn't find it acceptable to put a 9-year-old girl on hormones because of monthly bleeding in combination with von Willebrand disease. A long research began, and thanks to a personal hero, we learned that there were more options than just contraception. For a number of years, I have learned to give my daughter von Willebrand concentrate, and we inject her from 4 to 5 times a month during her menstruation. She still has heavy periods, and her periods still last from 8 to 10 days, but she can go to school most of the days. She dares to exercise again, and she goes out with her friends, and her quality of life has improved by 80%. And this is the personal story from Cathy. And with this, I give the floor to Laura to share her experience in Spain.
Okay, thank you, Daria, and well, good afternoon. I'm Laura. I'm 42 years old and I'm from a small town in Spain. The beginning of my history is different from Cathy's. When I was 8 months old, I had a massive bleeding and I was diagnosed at time with von Willebrand type 3. I know I was very lucky because I met a doctor who was interested in my case in this moment. I have heard stories like Cathy's many times, and recently in our group every day. The access to diagnostics in von Willebrand disease is very difficult, especially types 2. And if you don't have a major or a specialist hospital, it's even more difficult. I would also like to highlight the added difficult for women and girls. When a girl or a woman has a abnormal bleeding, it is not treated immediately, as in any case of a man. First, we are seen by several doctors. They try other things like iron, and finally, they give us the treatment we need for our bleeding disorder. My example, I was given factor 8 every time I have a nosebleed or a tooth bleed, but no doctor thought I will get my period, and as a consequence, at the age of 11, I had my first period, which led to a critical condition and 3 months in a hospital. Many girls bleed too much for months or years before their first diagnosis, or with the diagnosis, they see it's a normal bleeding. Even today, in a country like Spain, where we have a public health system that covers the necessary treatments for all patients, it is still difficult for us to have access to them. Fortunately, this is changing. Today, we have access to home treatment, both in demand and prophylaxis. And also at the beginning, the less trained clinicians think about the cost of treatments rather than the quality life of the patients. But the truth is that little by little, there is a great access. For me, since I've been on prophylaxis, I feel like I'm in control of my life, and I'm not dependent on whether if I do one thing or another, or whether I'm just going to bleed. This webinar, we will be discussing treatment options for von Willebrand disease. Just to say that I'm glad that meetings like this are taking place and that our community is hearing more and more about von Willebrand. Thank you.
Thank you so much, Laura. Baiba?
I can absolutely agree to what Cathy and what Laura said, because one of my dad's most terrible experiences was also when his tonsils were removed when he was a child, and that was like very long time ago, and there was no treatment at all. But in my country, we only have desmopressin as the only treatment for von Willebrand's, and at the moment we are still fighting for on-demand treatment with factor concentrates, because that is not absolutely available. We can have it only for planned surgeries, but when people have extreme situations when they need it urgently, it's not available. It's only available in the hospitals, and that's where I want to join Cathy's quote about the most important message that she wanted to give to others was that we have to know the treatment options ourselves and we have to fight for them, because also such a simple treatment as tranexamic acid, I didn't know about it before I heard about it in a conference like this. And then I started asking my doctor, can I have it for my bleeds, because the other options were not okay. And only then I got it. But I absolutely want to urge every patient who is listening to us to learn more about the disease and more about the treatment options. And I know that Professor Sophie Susen has prepared fantastic presentation about all the options that we can have. And let's give floor to her. Thank you.
So thank you, Beba. Maybe first I would like to thank you for this invitation. I'm very happy to be part of the steering committee of those webinars, and I'm also very happy to have been chosen to discuss about the treatment options, because I think it's a really important subject, as you mentioned. And if I can have a quick reaction on your stories, I think there is always room for improvement working together. And what your experiences highlight is that now we need to improve multidisciplinary practice, and we need to improve the way that we discuss with gynecologists, with gastroenterologists, with people working in the emergency department, and so on. So that's the first point. And the second one, maybe the most important one, is we need to convince all the community that there is a room for improvement on treatment options, and that's very important, and that researchers have now some solutions, and we need to move these solutions to clinic, and so really in particular for women. And with that, I don't know if the time to begin the presentation. Yes, okay. So I will share my screen. So my topic is the treatment options for patients with Willebrand disease. Here are my disclosures. I hope the screen is okay.
We still can see the next one. So
okay, so I must change. Sorry for that. I don't know why. It's going to work, no worries. Just a question of time, 5 minutes. Okay, I think it's okay now.
Yes, it is perfect.
Yes,
Thank you. So here are my disclosures. And for this webinar, maybe because it's part of the EuroBloodNet accreditation program, we have some learning objectives together. The first one is to describe the prophylaxis treatment regimen and the access to home treatment for Willebrand disease. The second one is to highlight that desmopressin doesn't work for everyone, and that we need to perform some trials and to have the type of Willebrand disease to decide for desmopressin treatment. The third one is the hormone treatment options for women, and I think there is a subject when with words when we use oral contraceptive in Willebrand disease. It's not an oral contraceptive, but really a full treatment option for bleeding, and words are important. In particular, when we are discussing with families and with young women, I think the Cathy's experience is very important for that. And at the end, we have different types and different treatment options. And I hope that I will, at the end of the presentation, will convince you that there is no only one Willebrand disease, but some subtypes, and it's different rare diseases among a rare disease. And you see, it's an heterogeneous disease with different types and subtypes. Here, depicted on the circle with different colors. And the severity is really variable within and between subtypes. And it's a rare disease, and it's, again, rare diseases among a rare disease. And the clinical management has remained unchanged essentially since more than 30 years, using VWF products, desmopressin, tranexamic acid, and hormonal treatment. And despite the treatment has not changed, there is really a burden that is much more appreciated right now, a burden of the disease. And the quality of life is really reduced in von Willebrand disease, and in particular in women. And because of heterogeneity, because of the low numbers for each subtype, there is an underappreciated need of new treatment options and of new developments. And there is also an issue on the way that the companies are developing new treatments, and it's really difficult to develop a treatment for a small number of patients. And it's really good to know that new treatment options are really currently under development. You can see there is a nice review from Caterina Casari and the group of Cécile Denis in Kremlin-Bicêtre. They have been involved in the development of such new treatments. But it's not the topic of today. I'm going to talk about the existing treatments and not the new developments. So, of course, it's the 6th webinar. So now you know perfectly von Willebrand factor and all von Willebrand disease. But we must remember that this von Willebrand factor is an amazing multimeric glycoprotein. And the function of VWF is depending on this multimerization, which means association of monomers. And this multimerization provides a really active function of VWF to bind to different ligands. And to bind, for instance, to factor VIII, to bind to collagen, to bind to platelets. And when you think about treating patients with von Willebrand disease, for sure you have different questions that you have to raise and that you have to answer. For sure, the von Willebrand factor activity should be maybe decreased because of the genetic abnormality of von Willebrand factor. But also the binding of factor VIII can be altered, and so there might be a decrease in factor VIII level. And also in some subtypes, type 2B, the number and the function of platelets could be altered. So when treating a patient, we have to have those questions in mind before deciding which treatment option we can give to patients. And there are different types of treatment. The treatments that can increase VWF and factor VIII levels, and what's called adjunctive therapies, but which are essential in the treatment of von Willebrand disease. And they have been classified by WHO as mandatory products, antifibrinolytics, and hormone treatments, meaning tranexamic acid, estrogen, and progestins, and intrauterine device with levonorgestrel. And looking at increasing VWF and factor VIII levels, you can increase those levels by infusion of desmopressin, DDAVP, with different routes of administration, or using VWF concentrates, plasma-derived, alone, or combined with factor VIII, or recombinant VWF. And that's all at the moment. And if you look at the general principles of treatment in VWD, which has been nicely reviewed by Frank Liebeck and Jeroen Eikenboom in the New England Journal of Medicine, well, in low VWF and type 1, you can use desmopressin, either intravenously, intranasally, or subcutaneously. But there is still the need, and the first treatment option, which is an alternative but is very important in von Willebrand disease and in all rare bleeding disorder, is antifibrinolytic acid, tranexamic acid. you can see it's always present. Whatever the type of VWD, you can use, and tranexamic acid is very successful in reducing the bleeding. In type 2, desmopressin in some types can be useful, but it's not always the case. And again, there is a need for trial, and we will talk about that later on. And you can use in type 2 VWD von Willebrand factor combined to factor 8 or pure VWF concentrate, and we'll go back to that again later on. And for type 3, the only solution, beside the very important use of tranexamic acid, which is always useful, even in type 3 patients, you can use VWF combined to factor 8 or VWF pure concentrate. And again, I will explain the importance of factor 8 later on. And so when we are seeing a new patient with VWD, generally we write or we decide a general treatment plan. And we do that for all patients with VWD and low VWF, meaning all patients with VWF activity less than 30% or antigen less than 30%. Or what's called now type 1 or low VWF, between 30 and 50%, and a bleeding phenotype. And for all those patients, the question that we have to answer and to write for the next visit and for the case of an emergency, we need to decide if the treatment plan should indicate if there's a need to correct factor 8 at beginning, meaning that is there at baseline a decrease in factor 8 levels in this patient? And is there a need for access to home treatment, not only prophylaxis, but also the possibility to have a treatment with a VWF concentrate at home for instance, heavy menstrual bleeding, which is not a regular, not prophylaxis, not only long-term prophylaxis, but at least one injection in case of an emergency. And we also have to decide what will be the treatment option, considering the different thresholds that we have in mind to treat minor bleeding and major life-threatening bleeding, minor surgery and major surgery. And for instance, for what we have, the treatment plans that we have in mind, and we must decide which treatment option in which situation for each type of VWD. For instance, for a mild to moderate, we need to have a peak on day 1, and then you can see a trough more than 30% after day 1. So we have a treatment duration for 1 to 3 days. In case of severe bleeding, you can see that the peak and trough are higher for sure, and the treatment duration is longer. And it's the same for the different interventions. So we have in mind, and we must decide what is the best treatment options for for the patient for all those situations. And even though not all the details are written down, we have to think about it and to perform all the exploration to answer all those questions and to have this in the medical records. And so what do the guidelines say, for instance, from surgery? Well, we have a recommendation suggesting to target both factor 8 and VWF activity more than 0.5 unit per ml, which is 50% for at least 3 days. And the recommendation suggests against using only factor 8, meaning that we need to have access to lab assessments for VWF levels and also for factor 8 levels, but not only factor 8 levels. And for minor surgery, we can use desmopressin or concentrate or tranexamic acid. And they suggest to give tranexamic acid only for patients with type 1 and a baseline VWF activity level more than 0.3 and a mild bleeding phenotype, and for sure undergoing minor mucosal procedures. So we have indications about which treatment to use. And in France, we have a national grant for all rare diseases, and we decided to implement care with a national emergency card for all rare diseases. But of course, it has been adapted for each disease. And here you got in French, please apologize for that, you've got the example for Willebrand disease. So this is a small card, and you can present the card to the emergency department, and you have indication about the type of VWD and also about the possibility to use desmopressin and the usual treatment for the disease. And we have policy between all treating centers. We have a kind of national procedure that describe when to use this card and what kind of information we put on this card. So that is used also for hemophilia, for all rare bleeding disorders, but it's adapted for each of the diseases. So now let's go more in details. The first treatment option is desmopressin. Desmopressin or DDAVP is not a specific treatment of VWD. It's the antidiuretic treatment. I mean, you can use the desmopressin in other indications, for instance, in anuretic patients. Desmopressin has the ability to bind to specific receptors in platelets or in endothelial cells, and the binding of desmopressin induces the release from Weber antibodies that you can see here in the endothelial cell, or in platelets, the alpha granules, the release of VWF, and the release of the factor VIII that is bound to VWF, you can see here, and also less in much more less important quantity TPA, but it's not the subject of today. And also it increases the expression of GP1B and P-selectin on the surface of platelets, which increase the ability of platelets to adhere to the lesions and to the exposed subendothelial collagen. And so that's not a specific way to act. But it's induced something that you are the normal synthesis of the patient. So it induced the release of the own VWF, which is stored in those granules, alpha granules, and Weber antibodies. But it's a short-term effect first. There is what we call tachyphylaxis. Tachyphylaxis means that there is sometimes exhaustion of the content. You don't have any more VWF in the granules because you have induced the release of all the stocks of VWF. So after 2 or 3 or 5 injections, you don't have any more VWF to release. And most important, very important to have in mind that you have a very variable inter-patient response. And due to this variable inter-patient response, we need to perform a test, what we call a test trial. We inject a dose of the DDAVP and then measure VWF antigen, VWF activity, factor VIII, and platelets 1 hour after the infusion. That reflects what is in the granule, that reflects the synthesis capacity of the patient, and 4 hours after the injection, which reflects the clearance, that means the elimination of VWF. And having all those results in hand, we can say the patient responds partially, totally, not at all, to the desmopressin injection. And you can see that it was pretty elegantly demonstrated by in the WIN study by the Dutch group that the desmopressin response depends on the presence of genetic variants. That means that it is important to know whether there is a genetic variant or not in the family, for instance. And you can see here that there is a clear difference in desmopressin response between patients with type 1 without, in green, or with, in blue, gene variant. and patients here in red with type 2 VWD. And we know for sure that in type 2, there is a qualitative abnormality of the VWF. That means that the activity can rise after the injection, but you see it's really much less more efficacious than in type 1, which is a quantitative issue in the VWF level. And you can see that it's quite easy to predict that in patients with type 1 VWD without variant, genetic variant, in their cohort, there is 100% good response to desmopressin, which is more mitigated in type 1 with a genetic variant. And you see in type 2, the proportion of good response is the inverse. I mean, when you have genetic abnormality identified in type 2 patients, you don't have a good proportion of good response. And here is just to illustrate that the inter-individual variation to desmopressin is explained by the genetic variant in type 1 and in type 2. So it's important for the diagnosis to have the genetic analysis, and it also helps to predict the response to treatment. So in general, what we applied is summarized in this table. In type 1 VWD, or in low VWF, for surgical prophylaxis or acute minor bleeding episodes, there is large evidence to support use of desmopressin. In type 2A VWD, generally it's avoided because of the defective multimer formation and release, because you don't have enough synthesis of VWF and a correct multimerization. So you release the abnormal VWF, but sometimes it can help. In type 2B, it's generally contraindicated because you increase the interaction between platelets and VWF, and there is potentially a risk of increasing platelet aggregates and thrombocytopenia. So it's usually contraindicated. In type 2M, it's like in type 2A. Generally, it's avoided, but sometimes it can help, and the test trial is always useful, except in 2B. And in type 2N, it can also be very useful. So in summary, most useful in type 1, contraindicated in type 2B. A test trial could be performed in other situations, and of course, no use in type 3. You don't have any VWF, so you cannot release something you don't have in your granules. And I think it's very important to keep that in mind. There are contraindications and restrictions with DDIVP. And that's also why there's here, again, room for improvement, and there is need for new treatment option. Really, desmopressin is good, but there are some restrictions. For patients with active cardiovascular disease, and for instance, for patients taking diuretics, it's contraindicated. For patients with seizure disorders, in young children, you cannot use desmopressin. In patients with 2B, again, as I already mentioned. And something rare, but very important to know and to highlight, in particular for general practitioners and for the families, and is the risk of hyponatremia resulting from free water retention. You must remember that desmopressin is the antidiuretic hormone, so you keep the water inside. You release the VWF, but also you keep the water inside. So there is a need to restrict the oral free water fluid intake after infusion. And so there is, again, a need for a really clear patient counseling about desmopressin that include strategies to mitigate risk associated with hyponatremia. So there is a need for education about the fluid restriction, patient, families, and again, our colleagues, anesthesiologists, and so on, because sometimes you think it's good to give a glass of water, but it's not. And also for cardiovascular disease. And that's a very important point, and that we always need to learn about that. So what do the guidelines say about DDIVP? One recommendation suggests performing a trial of desmopressin in patients with VWF less than 0.3. That's very important to have this trial. The recommendation suggests against treating with desmopressin in the absence of desmopressin trial. That means that in case you don't know if there will be a good response, you cannot use desmopressin, except for patients with at baseline level of VWF more than 0.3. Because in such patients, it can be presumed. Remember the slide with type 1 with high VWF at baseline can presume to be desmopressin responsive. But in such cases, okay, you don't perform a trial, but it is reasonable to obtain VWF levels in case of surgery to confirm response after administration. It means you don't have to it's not mandatory to perform a trial, but when there is a surgery, when there is a use of desmopressin, you need to have a blood assessment to control VWF levels after this injection. And in some type 2 patients, desmopressin can be useful. So you perform the desmopressin trial. It's useful to confirm diagnosis because there are some type 1 that can be misdiagnosed and some type 2 that can be misdiagnosed, and maybe to make the difference between the two of them, a desmopressin trial is useful. And desmopressin may be still useful in some instances in case of mild bleeding in type 2 patients. So apart type 2B, it's useful to have a desmopressin trial in type 2. And you must know that there are different routes of administration, that there is a shortage of the worldwide shortage of the nasal spray administration. But what I want to highlight with this slide is that you know that for each route of administration, there is specific vials, there is specific dosage that you cannot use IV vials to perform a sub-Q injections. You can see the concentration of the drug is pretty different. And whatever the route that you use, you must restrict free water intake less than 0.75 liters per 24 hours. That is very important. And now if we move to the VWF products, we can use VWF products, plasma-derived containing or not factor VIII or recombinant VWF products. We can use them on demand for treating bleeding events or for short-term prophylaxis, for instance, for surgery, or for long-term prophylaxis to prevent hemarthrosis, gastrointestinal bleeding, epistaxis, and menorrhagia. And as you mentioned, we have different products, and they are different because they are plasma-derived or recombinant, and they are also quite different regarding their content on factor VIII. You've got products that contain, let's say, same amount of factor VIII and VWF. You have products that contain some factor VIII, and you have products that contain very low or no factor VIII and only VWF. And you can see that the half-life is quite different. Okay, it's not tenfold differences between them, but there are differences. Looking at the multimers, and I told you that the multimer are very important for the activity of VWF, you can see that the ultra-large ones are only present in the recombinant VWF. And as you mentioned, there are some approvals between our institution and companies to bind such product, and for centers and another product for another. And to be perfectly honest, today, even though the products are different, we don't know if we need to we don't have any clear evidence to personalize in each situation the treatment by choosing one product among the others. And looking at the question about factor VIII, do we need factor VIII or not? You must also remember that in VWD, the synthesis of factor VIII, here is the chromosome in green, is normal. What is not normal is that the binding of factor VIII to VWF is not sometimes enough, and so the factor VIII is not protected from proteolysis and is decreased. But its synthesis is normal. It means that in such cases, if you bring VWF to protect factor VIII from proteolysis, you can see here, for instance, in type 3, and if you look at the factor VIII levels after infusion of a pure VWF without any factor VIII, you increase the factor VIII levels quite rapidly. Within 6 hours after infusion, you correct the factor VIII levels because the synthesis is normal. What is missing is the binding partner of factor VIII. And it has been shown in type 2A, you can see here, in type 2B, and in type 1, the normalization of factor VIII is something that happened in a couple of hours. And it's exactly the same when using recombinant pure VWF, devoid of any factor VIII. In a quite short period of time, you normalize the factor VIII levels after injection of its binding partner, the VWF. So what does it mean in a kind of practical point of view? And let's take the example of Envasure procedure. So in case of you have a minor procedure, in case of you are good responder to desmopressin, okay, let's go for desmopressin. But in case of non-responder of contraindication, or in case of major procedure, you need to have VWF concentrate. Because in case of major procedure, the answer with, even though you are a good responder, the answer with desmopressin is short, and you cannot use to protect enough for enough long period of time with desmopressin. So you use even in case of responder, you use VWF concentrate. And the question is, okay, do I have to bring factor VIII or not? Well, the first question to answer is the factor VIII normal at baseline, or is it decreased? And you can see that it's not so often that the factor VIII is decreased. And in the French cohort, for instance, if you look at type 1 patients, the factor VIII is normal in more than 2/3 of patients. And in type 2, it's 60% of patients that have normal factor VIII. That means that in such situation, in case of factor VIII is normal, you don't have to have in mind the need for correction of factor VIII at baseline. And in case of the factor VIII is decreased, the issue is only for the first injection, because as I shown you, after that, the factor VIII will rise with the VWF that you bring. So it's really important for the first injection, and you can provide some factor VIII on top of a pure product, or using a combined VWF and factor VIII product. And if you look at the products that are used in Europe, it's the US registry. It's not overall centers in Europe, but it's almost 100 centers in Europe. You can see that the use of pure VWF is increasing, and it's not an issue to manage procedures and bleeding with pure VWF. And you can see that the most frequently used is the combined with low factor VIII content, but at least it's important to have in mind that we can manage a lot of situations with pure VWF. So let's move to long-term prophylaxis. What was the definition of the long-term prophylaxis? It's a home infusion of VWF on a regular basis, which is not really precise, at least once a week, to prevent bleeding. And it was defined more than 45 weeks in the year on a regular basis during menstrual periods to reduce menorrhagia. And the main criteria to consider long-term prophylaxis in von Willebrand disease is, of course, joint bleed. And the recommendations until now were that 2 or more spontaneous bleeds in the same joint or 3 or more in different joints within the last 6 months. Epistaxis, 3 or more bleeding episodes requiring VWF or transfusion within the last 6 months. Gastrointestinal bleeding, 2 episodes. Amenorrhagia with PBAC score quite high, or requirement of VWF or transfusion within the past year. The guidelines have simplified, and I think it's good for our community, simplified the definition of what's the prophylaxis. And now the definition is a period at least 3 to 6 months of treatment consisting of VWF concentrate at least once weekly. But I mean, you are considered as receiving prophylaxis even though it was not the 1 year treatment. Or for women with heavy menstrual bleeding, use of VWF concentrate at least once per menstrual cycle. So it's a more inclusive definition, let's say, more practical definition. And of course, prophylaxis works quite well. You can see this is the VIP study. The VIP study was a European effort to try to collect before and after results on annualized bleeding rates of patients using prophylaxis according to the bleeding type indication and according to the type of VWD. You see the different colors in the bars indicate the bleeding site. In blue, the epistaxis, in red, the joint, in brown, the GI bleeding, and in purple, menorrhagia. And you can see that globally, the before and after is okay. The prophylaxis reduces globally the rates of bleeding in patients. But you can see that it's not exactly the same results according to the different types of bleeding. And for instance, in type 2, the efficacy on reducing GI bleeding is much more evident that, for instance, decreasing the joint bleed in type 3. So again, the different colors and the evolution of the different colors, meaning that the evolution of the different types of bleeding under prophylaxis is reflecting the heterogeneity of von Willebrand disease. And again, the idea that we cannot apply a unique recipe to treat patients, and we need to look very closely to this, to the bleeding events and to the evolution of the rates of bleeding in patients receiving prophylaxis. And here is the result of the study on prophylaxis using recombinant VWF. And you see on the left-hand side of the slide the patients that were prior on-demand, and on the right-hand side, the patients that were prior receiving prophylaxis. You can see again that prophylaxis is quite a good treatment to reduce bleeding, because you can see here the percentage of patients with 0 bleeds increased a lot. It was significant. You can see here that there was no patient with 0 bleeds, and after introducing prophylaxis, it's 84.6% of patients with 0 bleeds. But what you can see, and in my opinion, what you can see in patients that were on prophylaxis, the percentage of patients with 0 bleeds is quite low when comparing to the hemophilia treatment with the new treatment options right now, which are more than close to 80% and above 80%. And here we are again a little step behind. Meaning that even with a good treatment, even with prophylaxis, there are still bleeding events in von Willebrand disease. So, in summary, what do we know so far about long-term prophylaxis in von Willebrand disease? So, most patients treated with prophylaxis at the moment are type 3 mainly, and some type 2. Reason for initiating prophylaxis is gastrointestinal bleeding and joint bleeding in adults, with mixed results for gastrointestinal bleeding, epistaxis and joint bleeding in children. And secondary long-term prophylaxis is efficacious in reducing bleeding in von Willebrand disease, and there is really low certainty of evidence because of very few studies. And efficacy depends on bleeding symptoms. You have seen that joint bleeding is quite okay, but for GI bleeding, it's not working very well. All products have been used. You can find some results with all the products in the table with high or low content of factor VIII. But at the end of the day, there are very few data and very few evidence for defending and promoting the prophylaxis for everyone with VWD. But the guidelines say that in patients with VWD, with a history of severe and frequent bleeds, given the experience that I've shown you, there is a suggestion using long-term prophylaxis rather than no prophylaxis, and that's the really what's applied in a lot of countries in Europe, I think, even though not everywhere. But I think what's also very important, given the burden of the treatment when you are receiving prophylaxis, is the need to reassess periodically the efficacy of the prophylaxis in patients and the evaluation of the treatment need and the reduction of bleeding using prophylaxis. I think that's very important. Each time, at each visit, you need to reassess, is it useful or not? And for instance, for GI bleeding, really, it's not really the case. And it must be a discussion with the gastroenterologist and of course with the patient. And now let's move to heavy menstrual bleeding. Well, it's not a surprise if I tell you that heavy menstrual bleeding is really a very frequent symptom in patients. It's not something new. We know that for more than 25 or 30 years, even though it's sometimes very difficult to highlight in a family because it's useful in the it's not useful. It's used in the family. Everyone has got heavy menstrual bleeding, so it's something normal. So sometimes you've got to question really in details the patient and the family to highlight that there is heavy menstrual bleeding. And roughly, it's half to all patients with VWD that have heavy menstrual bleeding. And for sure, it's a source of depression, anxiety. There are a lot of publications. The two last I've seen here, you see, in 2023 and in 24, it's more and more studies, larger studies are coming with that, showing that it's really an issue in women with VWD. And so again, there is again a room for improvement of treatment in such situations. And the recommendation suggests that in women who do not wish to conceive, to use either hormonal therapy, such as use of combined oral contraceptive. It's exactly the case for the daughter of Cathy. And I think, again, it's really a problem that what is used is the word oral contraceptive, because in the situation of von Willebrand, it's not a contraceptive, but a treatment. Or levonorgestrel intrauterine device, or tranexamic acid. And such treatments have been evaluated in different studies, and they are better than desmopressin to reduce heavy menstrual bleeding. In patients who wish to conceive, there is a hole there is something here very difficult, because the only thing we can use is tranexamic acid over desmopressin. And it's sometimes a difficult situation, because in patients with type 3, for instance, stopping the hormonal treatment is very frightening because of the fear of recurrences of bleeding. So I think here there is really a need for improvement. And an important good practice statement is that the panel encourages the development of multidisciplinary clinics in which the gynecologist and hematologist see the patient jointly. And even though they don't see the patients jointly, we need to work together in a frequent basis. We need in each institution to have one or two gynecologists with whom we work and who know the specific problems of patients with heavy menstrual bleeding in rare bleeding disorder. That's very important. It's exactly the same for gastroenterologists. And there is a paper that's quite interesting that has been published last year. It's a crossover study using, what's interesting is that it's in mild to moderate Willebrand disease. And the idea was to compare the use of tranexamic acid alone versus the use of one injection of recombinant VWF to decrease heavy menstrual bleeding. And it was a crossover study, meaning that the patients that were included have 2 cycles with one treatment option, and then we change in each group. And so we have the results. We compare the 2 treatment options in the same patients, which are their own controls. And what's very important, I think, is that although there is a modest decrease in bleeding with tranexamic acid versus recombinant VWF group, which was not really clearly significant, and the protocol could be criticized because it's only one injection and so on, what I think is very important is that in no cases the bleeding returned to normal range. So that means that using either tranexamic acid or recombinant VWF, you don't, in mild to moderate VWD, you don't normalize the menstrual bleeding. And you don't change any quality of life. And the most important, in my opinion, result of this study is that, okay, VWF is not superior to tranexamic acid, but that means that we need to share our decision on the best treatment option, and there's no clear evidence of one above another. And to finish, I just want to highlight the off-label use of emicizumab in Willebrand disease. And as you know, emicizumab is correcting the factor VIII level in patients with haemophilia. It's a bispecific antibody mimicking the factor VIII. And an off-label use has been described in patients with low factor VIII activity, meaning in type 3, and in particular in type 3 Willebrand disease with autoantibodies against VWF, meaning that in such cases, usually the only treatment options until now has been recombinant factor 7A or FIBA. And there are, the slide is not up to date because there is now more than that, maybe 15 cases that have been published using emicizumab to correct the factor VIII level in type 3 with or without inhibitor. No adverse events have been reported until now, but you must keep in mind that it's not a controlled clinical trial. There are spontaneous bleeds, sometimes improvement of quality of life, but very limited follow-up. There is a clinical study, an investigator-initiated clinical study that is recruiting, and maybe we will have some results. And I think there are one other study to come in type 3 patient. What's interesting with this treatment is that it's a sub-Q injection and that you correct the factor VIII. So in conclusion, I hope that I have convinced you that in VWD there is not at all one size fits all, not at all. You have to consider the type of VWD, and so sometimes it's difficult to define the molecular defect, the individual history of bleeding, where the patient lives, and the availability of the product in the country, in the treating center, What's the expected treatment duration? What are the additional risk factors? And again, for instance, for hyponatremia and antihypertensive treatment, it's a contraindication. And so there is really a need for personalization of treatment, choose the product, choose the treatment regimen, perform a systematic and regular evaluation of the efficacy of the treatment plan, and choose according to the best knowledge in high-risk patients and situations, and really in a shared decision process. Sometimes patients want to stop their prophylaxis and we have to listen and to restart. Again, there is a room for improvement of all the treatments in VWD. And with that, I thank you for your attention.
Thank you very much to you for this comprehensive presentation, very clear. And we have received already many questions, so we'll go straight with the first one. We don't let you breathe.
Okay.
Can desmopressin stop working over time? I mean, over the years, it may never work for us.
Usually, it's as it has been shown by the Dutch group. Usually, you answer this in the same way with time, but sometimes you get contraindications. That means that with aging, we try to avoid to use desmopressin. And for instance, in a long time frame for a surgery, we cannot use desmopressin in patients with VWF, let's say around less than 0.3, because we know that after 3 or 4 injections, the levels won't rise again. And there is an increased risk of hyponatremia when you repeat the injections. So usually we keep that for minor surgery, minor bleeds. And again, it's my main message, because when it happens, it's always awful. Look at the natremia and the water they drink.
Okay, thank you so much. The next question that we have in chat: can VWD patients have inhibitors the same as hemophilia patients?
Yeah, they can. It's quite. It's not a frequent situation, and it's the pathophysiology is not exactly the same than in factor 8. I mean, we cannot look at the exposure days and so on. It's really it's more difficult to it's really difficult to predict who's going to develop an inhibitor. Of course, it's in type 3 mainly. Sometimes it has been demonstrated that some defects are more prone to some molecular defects are more prone to develop inhibitors, but it's such low numbers that it's really difficult to have a good prediction of that. So that's why we must always have a look at the VWF levels in type 3 receiving VWF, and we must be very cautious in case of signs of bad tolerance of allergia, for instance. And what's frequent looking at those inhibitors is that they not only are targeting VWF, but are also, given the binding of factor 8 to VWF, they are also directed again against factor 8 very often. So when we search in the lab the inhibitory effect, we find an inhibitory effect against factor 8 and against VWF. So the only solution until now for those patients was recombinant factor 7A or FIBA. And what's really interesting with emicizumab is that we can use, and at least it provides protection regarding the level of the equivalence of the level of factor 8. And that's why it has been used at first in patients with VWD and inhibitors type 3 with inhibitors, the first emicizumab off-label used.
Thank you so much. You actually answered the next question, which was chat about inhibitors. Yes.
Exactly. So The next one, I think you didn't answer, but I already excuse myself if it was answered. Is recombinant von Willebrand factor prophylaxis also accompanied by factor VIII?
Yeah. Okay. So I'm gonna try to explain it better. I hope. When you have a type 3, let's say when you have a severe VWD, again, your synthesis of factor VIII is normal. And if you have low level of circulating factor VIII, it's because you are missing VWF. If you bring some VWF, you will increase the factor VIII levels because the factor VIII is in normal quantity. It's just only that it's not protected when there is no VWF. So if you use pure product, I mean, recombinant VWF is devoid of factor VIII. It's pure VWF. In a couple of hours, the new VWF in circulation will stabilize factor VIII, and you will have an increase in factor VIII levels. So, for instance, when you have a regular prophylaxis with recombinant VWF, your factor VIII level is not decreasing, and it has been shown that in patients with prophylaxis using recombinant VWF, between 2 injections, you have a sustained increase in factor VIII levels around 40% or something like that, because there is still a stabilization of factor VIII. I'm not sure it was your question, Laura, but I can explain it again if you want, but I don't know if it was the exact question you raised. Yes? Okay.
And so I have the next question, but I'm not sure if it's to Mariangela actually. Where can patients who have no excellence centers or EuroBloodNet members in their country get recommendations for treatment?
Oh, sorry, for patients?
Where can patients who have no excellence centers or EuroBloodNet members in their country get recommendations for treatment?
It's a good question. I mean, first, it's not to make some comments on EuroBloodNet, but you have a lot of centers of EuroBloodNet across Europe. So maybe you can search for a correspondent of EuroBloodNet in your country. I think it could be useful. And some advices can be provided, even though, and maybe some medical consultation that we have, maybe it's feasible in some countries. It's always difficult to provide general treatment options when you don't see the patients, when you don't have all the results. And as I mentioned, we need to know the type, the subtype, to provide a good treatment option. So my first advice is to look at the website of EuroBloodNet and to try to have at least one visit at a specialized center. I mean, when you have a mild form of VWD, it's not always mandatory to have a frequent visit in a highly specialized center, and at least at once to have a statement of the type and the best treatment option, and the definition of the best treatment option can be a good option. But really, again, beside looking at EuroBloodNet website, I don't know.
It was a trap question from Baiba. So
okay, thank you, Baiba.
By the way, Sophie, you overpassed the exam of EuroBloodNet. Well done. Thank you. I can add few information, but you said it all. So indeed, we can have 3 roadmap to recommend you. The first one is indeed to search for expertise on the website, because we have a mapping of expert center per disease. If you don't sign it, you can contact us and we will try with our network and internal mailing list to identify expert for you. If this step is lacking, like we cannot identify any expert in your country, if it's an European member state, we can go through or the cross-border health directive pathway or social security regulations. So see with the collaboration among member states if we can provide you access to treatment or second opinion consultation or diagnosis in another country being reimbursed in your home country. This could be possible, depends on many factors. Or indeed, we have a platform of teleconsultation where we can request expert of other country to analyze a complex cases of any European member state. So those are the three recommendations I could give you.
Thank you so much, Mariangela. And the last question, at least for now, that I have in the chat, are there any restrictions to use emicizumab off-label in type 2N, or can a patient and a hematologist simply decide to try it?
Okay, it's a good question. On a theoretical point of view, it can be useful in all patients with a defect in factor VIII. But the issue is that when VWD patients bleed, we don't know if the bleeding event is due to the decrease of factor VIII or the decrease of VWF. For sure, mucosal bleedings maybe are more due to the defect of VWF, but to correct factor VIII can be useful in reducing such bleeding. So this is the first question. So we don't really know if to correct factor VIII will be good enough to correct all bleeding symptoms. But let's say that, for instance, in severe type 2N with very low level of factor VIII, like in type 3, it could be useful to prevent joint bleeds, for instance. And again, it's in theory, it's a good treatment option, but and it seems to be really in the case that have been published so far, it has been useful, but we don't have really a lot of evidence for that. We don't have any follow-up of those patients. And I think it should be, first, we need clinical trials. And we need to collect, and we need to have to collect all the information available. We need to share this information at the European and international levels. I mean, people have been treated with this product. We need to know if it works or not. We need to have follow-up, and we need with the company to obtain those results, I think, because it's so rare that we need to have this information. And we need maybe a clinical study, more a controlled one, meaning that we will have outcomes listed very precisely, and we will have evidence on the potential efficacy on other bleed symptoms than joint of emicizumab or bispecific antibodies, because my mate is coming and is will be probably also used off-label used in VWD. But again, type 2N in theory is a good indication, because in type 2N patients, the only thing which is impaired is the binding site of factor VIII. So if you bring emicizumab, you correct the factor VIII levels, and in type 2N patients, VWF acts normally to bind platelets and vessel walls. So in theory, it's a good treatment option. And for type 2N, another good treatment option is efanesoctocog alpha, because it's, you know, this new high sustained factor VIII activity level, which is factor VIII bound to the domain of VWF that stabilized the factor VIII. So it's really the best treatment option for type 2N, severe type 2N patients.
Thank you so much. I don't think that we have any questions in the chat. If only someone wants to ask a question like this, to raise a hand. No questions from Nicolas Giraud this time, which is surprisingly.
My fault, maybe.
Piper.
Can I remind about the heavy menstrual bleeding that there is this very simple rule 7-2-1, which means that if the menstruations are longer than 7 days, if you need protection, to change protection more than 2 in every 2 hours, or you use 2 protection items at the same time, or you have the clots which are bigger than €1 coin, definitely seek attention, medical care. And that will help you understand what is normal and what is not normal regarding menstruations. Thank you.
And ask your mother how it was if she's not menstruated anymore, and your grandmother also. You're right, definitely.
Angela?
Maybe we can remind next session. So we'll be after summer break on the 19th of September. So we'll have almost 2 months of break. I hope you all enjoyed the summer. And so we will talk about surgery with Professor Flora Peyvandi. So we will start again the session, and in the meanwhile, we will publish on our both e-learning environment the first videos of the first 6 sessions during the summer. So it will look like we stop, but we will not stop.
Absolutely. And there are comments and thanks in the chat to Professor Susan for very educational session. And thanks for that it has clarified a lot of things to patients, and I believe also to clinicians. It's always a learning curve for both sides.
Indeed. So thank you very much to all of you, for especially Sophie, Baiba, Cathy, even if she wasn't here, and Laura, for sharing all your expertise on Willebrand disease. Thank you very much, and have a nice summer to all of you.
Thank you for the invitation.
Thank you all.
Bye-bye.
Thank you. Bye-bye.